So our next speaker is Nathaniel Day. Nathaniel's very kindly joining us from Alberta, currently middle of their working day. I have to say, when I heard about Nathaniel's service, I had service envy, and I'm sure you will too when you hear about it. So I'll ask Nathaniel to take it away.
Thanks for that kind introduction. Good evening for you, good afternoon for me. Thanks for the opportunity to speak today. My name's Nathaniel Day, and I'm the physician lead and developer of Alberta Health Services Virtual Opioid Dependency Program. We'll go to my next slide. We all know that medication-assisted treatment, or opioid agonist therapy, which is what we call it here, whether it's methadone or buprenorphine or another product, all have significant barriers in place, usually with the explanation that they're needed to reduce diversion and protect client safety and community safety. However, I believe that many barriers are tradition-based rather than evidence-based. And I ask myself, if you or I or one of our loved ones needed this care, what barriers would we eliminate for them or for ourselves? I've seen people who've lost everything they owned so that they could get to an urban center for daily witness dosing. And I know that I would personally struggle to fit daily dispensing and weekly follow-up visits in an in-person clinic in my busy life. And so if the current approach wouldn't work well for us or for our families, why do we impose it on others? Next slide. This is our VODP vision. The intention of this document is to embolden our staff to meet people where they're at and to allow flexible and evidence-based care that balances safety with access. Next slide. By way of context, our program was developed in 2016-2017. At that time, we were horrified to see the growing impact of the fentanyl crisis in our jurisdiction. As you can see, overdoses were growing across our province, which I'll point out is a geographic area about 20,000 square kilometers larger than France. We wondered if it could get worse. Next slide. And indeed it has. Though we had a large decrease in deaths in 2019-2020, with COVID, we have surged to a new record with 18.6 deaths per 100,000 population, almost entirely from fentanyl and carfentanil overdoses. Next slide, please. We recognized that though the overdoses were province-wide, access to treatment was restricted to our larger urban centers. This map shows Alberta Health Services, our public taxpayer-funded system, telehealth sites. We leveraged those sites and any pharmacy that would cooperate with us, as well as labs were available, to develop a full-service virtual clinic that could help people no matter where they live. Next slide. We used existing infrastructure and now use a free to the client but still encrypted version of Zoom to reach people with as few barriers as possible. All visits, including intakes, are virtual. If a client is best served somewhere else, we try to support them now and connect them with the most appropriate care going forward. Next slide, please. Our program has three key streams. We have a same-day medication start service. If someone has been using street opioids, we aim to get them started on treatment the very same day that they call in. In fact, often I'm speaking with people who just phoned in 20 or 30 minutes before. We do a screening intake, we review our provincial data system for past testing, and we have an in-the-moment physician consult, all done virtually. If they need testing like an EKG or have never had a urine drug screen, we'll start them now in the moment of crisis and get that testing arranged for as soon as practical. The second stream is our transition service. We recognize that, number one, we don't want to be the sole provider in our jurisdiction of medication-assisted treatment. And number two, some clients are best served face-to-face. So we need to get people reconnected with past providers or connected with face-to-face providers if available in their home community. This service is particularly effective for connecting people who were started on medications in the emergency department, corrections, detox, or other settings. They can connect with us, get their today needs met, and receive appropriate care until the bridging is complete. You will see that this service does impact our client retention numbers, but we think that this is an invaluable service to people. So for example, if someone today presented to the emergency department of any hospital in Alberta right now with an overdose, The physician could prescribe Suboxone to them for them to start there if appropriate or at home. Our staff will proactively reach out to the client 7 days a week before the next dose is due, review how they're doing, liaise with our prescriber on call, adjust dosing, and bridge care as needed until they have an intake with us or with somebody else. We also know that some people do not have access to care in their home communities, or that they're not likely to be well served by a face-to-face model. For example, this could range from Indigenous clients who live remotely to people who are transient or people who are working in resource extraction, which is very common in our jurisdiction, where, if they're working in forestry or in the oil and gas industry, they might be working and living in different locations each month of the year. For these people, we have ongoing care streams to meet them where they're at and connect virtually for longitudinal care. Next slide. I like this picture. This is from the Jasper area of Alberta. So when COVID is all done, please feel free to come and visit us. I appreciate the symbol of the bridge connecting two places and the remoteness of some of our jurisdiction. Unlike many programs that started virtual care during the COVID crisis, we have the luxury of data going back for the last few years, and I'd like to share some of our results. Next slide. Our program is growing rapidly. We already surpassed our 2019-2020 data about halfway through this fiscal year. In January, we had over 300 admissions alone. You'll note that our discharges are high, but that's by design, and you'll see that our median length of stay dropped. And we see that whenever we have surges of admissions, and we expect it to stabilize over time. The most important figure, in my opinion, is our median wait time of 0 days. Next slide. This data is client self-reported data and is collected by clinical program staff. Although this sort of data is never 100% reliable, we're confident that it does reflect the clinical picture that we see. We see our drug use drop over time, and we see our poly drug use drop over. Next slide. Next slide. Thank you. The BTOM scores, so brief treatment outcome measure, was designed for people who are in treatment for addictions. And the social functioning aspect of the BTOM score demonstrates improved social functioning as scores drop. We're in the process of publishing a paper which goes into much more detail of some of our results. I want to point out that this drop or this improvement in social functioning in our clients is statistically significant. We also see large reductions in high-risk outcomes and decreased emergency department utilization, as well as, not shown on this slide, significantly reduced hospitalizations for our clients. So despite being virtual, I think that we are seeing evidence that this kind of care can be effective, even life-changing, despite the absence of a face-to-face component. This allows us to expand reach and is very cost-effective when compared to establishing multiple bricks and mortar clinics geographically. Furthermore, the service can then be scaled to improve. For example, we operate 7 days a week, 12 hours a day, 365 days a year. If we had multiple clinics with small clinical teams, it would be impossible to provide that kind of service. Next slide. We're also very pleased to report that our clients are very satisfied with the service. Over 90% of our clients give a client satisfaction score of 8 or more out of 10. Clients do tell us that there are opportunities to improve, most commonly around what I would term access to pharmacy, to telehealth sites, which, by the way, we expect to improve now that we've been given permission to use Zoom rather than just telehealth sites alone, and with communication. Next slide. This final slide has a picture of Edmonton, which is my hometown. I again appreciate the bridge and the context. A completely virtual solution is safe and effective for clients. And we have a duty to challenge traditions of care contributing to improve patient outcomes. All of us work in some of the best funded health systems in the world. If we can't solve the challenges in our systems, who will do it for us? Thanks again for the chance to present today.